Examination of the neck is another very important skill in surgery. We can examine the neck for various conditions, for lymph nodes, for swellings, but the most common that we see is examination of the neck for the thyroid, enlargement of the thyroid gland, which is a goiter. Now, before we do this, one has to take a history. If one is examining the neck for a goiter, first one needs to know how it started. If the patient had noticed a swelling or someone else had noticed a swelling, and then inform the patient. Now, also whether it's been progressive, that is increasing in size with time. And furthermore, if there are associated symptoms. Now, there are some classic symptoms that are associated with overactivity of the thyroid gland, that is thyrotoxicosis. And one must go in great detail to establish this. The most dependable symptom of thyrotoxicosis is what we call heat intolerance. That is, the patient feels unusually hot when people around him or her do not experience that. To determine heat intolerance is not easy, but one should try and compare the patient's experience with the experience of people close to him or her. For instance, the patient's reaction to the atmosphere when it's with the spouse. Does the patient prefer the windows open all the time when the other partner prefers it closed? This is one useful way of determining whether the patient has heat intolerance or not. That, in fact, is the most dependable symptom of thyrotoxicosis. There are, of course, other symptoms of thyrotoxicosis. That is, an increased appetite, more than usual, a ravenous appetite, combined with progressive weight loss. The patient is eating more and losing weight at the same time. This is another dependable symptom of thyrotoxicosis. Whether the patient has palpitations, whether the patient has tremors, and whether the patient feels edgy, rather nervous in interactions. But the most important of all these symptoms are emphasized in weight, heat intolerance. So now you come to examination of the patient for the enlargement of the thyroid gland, that is goiter. And as usual, we go through the fundamental processes of inspection, palpation, percussion if necessary, and auscultation. That is looking, feeling, sounding, and listening. What do we do when we inspect? We must confront the patient and expose the neck from the chin right down to the nipple line, and then look straight at the patient and get the patient to swallow. Now, that could be a nervy point. The patient may, at that point, not be able to swallow. So one should always have a glass of something by, and then one can ask the patient to take a sip and then swallow, so you can observe whether that lump moves or not. This is crucial. The most important physical sign is whether the lump moves with swallowing or deglutition. And any lump that moves on swallowing must be attached to the larynx. And there is a fascia coming from the larynx that overlies the thyroid gland, which makes the thyroid gland move with deglutition. Now, if that swelling is in the midline, and particularly if it's not too big, then you would also have to test whether that swelling moves with protrusion of the tongue. So one takes hold of the swelling. It is important at this time to hold the gland. That is just not only observing, but actually take hold of the gland, because it is easier to see the movement when you are holding the gland. You get the patient to open the mouth and then slowly shoot out the tongue, and you will see a drawing up of the lump if it is attached. And that means that lump is a thyroglossal cyst. A thyroglossal cyst, of course, is related to the thyroid gland, but a thyroid that is enlarged will not move with protrusion of the tongue, whereas a thyroglossal cyst moves with protrusion. Why is that so? Because in development, part of the thyroid gland comes from the pharyngeal pouches, which come from the base of the tongue. And of course, with development, this tract will atrophy and become a cord, so that when the tongue is protruded, the thyroglossal cyst moves with the protrusion of the tongue. Now, the other bit of procedure in inspection is to see if there is any other lump in the neck, or any undue accentuation of the vessels of the neck, congestion of the vessels, the neck veins, if they are congested. It's important to observe. The next step is palpation, and we start palpating the thyroid gland from in front, and so as not to forget, go straight to identifying the trachea, which is related to the goiter. There are two ways of palpating for the trachea: from below and from above. From below, you palpate in the suprasternal notch. Put two fingers in the suprasternal notch, and if you press gently backwards, you might feel the trachea behind. More often in the goiter, you cannot do this. So we usually palpate the goiter, the trachea, from above, and you look for a midline prominence. You should really start from the highest prominence, which is the hyoid cartilage, the hyoid bone. And below the hyoid bone will be the thyroid prominence, the Adam's apple. And below that, of course, you feel the cricoid. And below the cricoid is the trachea. If the trachea is shifted, you will see it deviating from the midline. Usually, these thyroid swellings may be asymmetrically enlarged. So the trachea will be pushed away from the larger side. That is, the side, the larger larger thyroid lobe. And this is important to determine whether the trachea is shifted to one side or the other. Then from in front, now you go to the back. Stand behind the patient. The easiest way to feel the thyroid lobes is to stand behind the patient and apply your fingers to the sides of the neck, and so as to relax the muscles and make it easier for you to feel the thyroid gland. You get the patient to slightly bend the neck forwards. That relaxes the sternomastoid muscles, makes it easier for you to palpate the surface of the goiter. And as the palpation goes on, you could relax the neck even further by bending the neck slightly to one side and palpating on the side that is relaxed, and then to the other side and palpating the other side when it relaxes. Now, you having studied the surface of the gland, you see to whether the lamp moves or not. You can test for mobility, and the surrounding muscles are the sternomastoid muscles. So you test its relation to the sternomastoid muscle. You should try and get the sternomastoid on one side to contract by getting the patient to push the chin against your hand, and you see the muscle on that side becoming prominent, and you see the relationship of the gland to that muscle, and you do it in the opposite direction, and you test the relationship of the gland to that muscle also. You test for hardness, that's the consistency of the gland. Having done that, the next step in the palpation is to see if there are any lymph nodes, and you examine for lymph nodes of the neck comprehensively, starting from the submental lymph nodes, the chin, then submandibular, going backward posteriorly, and then to the upper cervical lymph nodes, and then following the lymph nodes down to the lower cervical lymph nodes and down to the supraclavicular fossa. So you have comprehensively examined all the lymph nodes in the neck. If there should be any enlargement, one of these would be involved. The next step is listening to the gland for evidence of excessive vascularization. This will show as a bruit. You hear the sound of blood rushing through the vessels, and the vessels in question are the superior thyroid vessels, which are usually on the superior border of the enlarged thyroid gland. And one puts one stethoscope on this superior border on each side. Now, there are two listening points on the stethoscope. There is the bell and the diaphragm. The kind of sound that we hear from a highly vascularized thyroid gland is best heard with the bell. So one uses the bell over the superior border of the thyroid gland, and you listen for the blow, which is like a blowing noise over the superior border. Finally, you come to determine whether you can get below the thyroid gland or not. The goiter, whether you can get below it. Is there a retrosternal extension of the gland? And this, again, is best done standing behind the patient and putting your fingers below, insinuating the fingers between the gland and the suprasternal notch, and getting the patient to swallow again. Always in examining the thyroid gland, this procedure comes in of swallowing. Now, if the patient swallows, the gland rises up. Usually you can insinuate your fingers between the lower border of the gland and the suprasternal notch, which means that there is no retrosternal extension. It's very important to do this. Now, there is a technique of ascertaining this through percussion. That is percussing the second intercostal space over the sternum. Now, this is only useful when there is a gross enlargement of the thyroid gland, and it's not really recommended. Once you can get below the gland. You can insinuate your fingers between the lower border of the thyroid gland and the suprasternal notch. Then you can assume confidently there is no retrosternal extension. Now that brings us to the examination of the thyroid gland itself. But there are other things to ascertain when you are examining the thyroid gland. That is, for evidence of excessive activity or the otherwise. Now, first you have to check the patient's pulse. This is useful. Pulse rate of over 90 in resting situation, but this is hardly possible in the clinical situation. So pulse rate certainly must be taken, but the conclusion you draw from this will be determined by the circumstances under which you examine. So we don't put too much reliance on the pulse rate at the time you examine the patient, although I emphasize it should still be done. Having taken the pulse, you then examine the patient's hand, looking for evidence of excessive sweating. Under normal circumstances, there shouldn't be too much moisture in the hand. It should be reasonably dry. But the patient who is toxic will have rather sweaty hands, and you do it on both sides. Next, you test for stability of the hands, getting the patient to stretch the hands forward and open the fingers. And in these circumstances, you can see if there is tremor. Tremor could be quite gross, or it could be very fine. It could be so fine that you may not be able to notice it. To accentuate this, it is advisable in those circumstances to put a sheet of paper on each hand, and then you observe it very carefully. You will see that the paper will exaggerate the fine tremor that may otherwise have been missed. Having done that, the next thing to look at is the patient's eyes for evidence of exophthalmos. Now, exophthalmos shows by protrusion of the eyeball, and we're looking for protrusion of the eyeball or proptosis. This you can do by standing behind the patient and looking across the forehead and the supraciliary ridges. You could see the eyeball beyond that ridge. Then there's evidence of proptosis. But it's even easier if you look at the eye from in front. The normal configuration of the eyes, the lower limbus should be tangential to the lower eyelid. There should be no white of the eye or sclera between the lower limbus and the eyelid. In proptosis, the white of the eye is exposed in the lower part. That is, the limbus, the lower limbus, is a white of the eye between the lower limbus and the lower eyelid. Now, when you look at the other side, the upper eyelid, here we're looking for lid retraction. And under normal circumstances, the upper eyelid is almost tangential to the pupil on the upper eyelid. And if there is retraction of the upper eyelid, the limbus gets, the eyelid gets further and further from the pupil to the point of exposing the upper limbus. And when lid retraction is extreme, then the white of the eye may also be exposed in the upper part of the eye. This is lid retraction. Now, you could also test for lid lag. That is, you get the patient to follow, steady the patient's head with your hand, and get the patient to follow your finger, raising your finger up and let it come down slowly. And normally the eyelid should follow the eye down. But in the patient with thyrotoxicosis, if there is lid lag, there will be a short interval when the eyeball is lower than the eyelid, and this is what we describe as lid lag. The combination of proptosis, lid retraction, and lid lag, plus restriction of eye movement, which we call ophthalmoplegia, is called exophthalmos. So there are really 4 components: proptosis, lid retraction, lid lag, and ophthalmoplegia. This constitutes exophthalmos. These are the eye changes in thyrotoxicosis. Of course, this particular patient we have examined is euthyroid. He doesn't have any of the eye changes that go with thyrotoxicosis. The eyes here are entirely normal. You could see that the lower eyelid is tangential with the lower limbus, and the upper eyelid is tangential to the pupil, which is normal. Finally, before you finish your examination, you must look at the lower leg, the foot, and the lower shin of the patient, looking for evidence of pretibial myxedema. That is thickening of the skin with some loss of hair and non-pitting edema. If you press on the ankle and the foot, although there is some swelling there, it doesn't pit, and the skin in that area is more coarse than usual. This is further evidence of thyrotoxicosis. And that brings you to the end of examination for a goiter.